Recording from the Sunshine City, St. Petersburg, Florida, overlooking beautiful Tampa Bay, this is the Sonography Lounge, sponsored by Gulfcoast Ultrasound Institute. This podcast is dedicated to medical professionals and patients around the world interested in diagnostic and interventional ultrasound. Our podcast will discuss everything ultrasound, from news, trends, career paths, new technology, and industry updates. Hosted by Lori Green and Trisha Reo of Gulfcoast Ultrasound Institute, they bring over 4 decades of experience in the ultrasound profession and are here to guide you through this journey. Now sit back, relax, and enjoy.
Hello, everybody, and welcome to the Sonography Lounge, sponsored by Gulfcoast Ultrasound Institute, where we are conducting our after-hours open mic session.
Boom.
Boom. My name is Lori Green, and I will be co-hosting today's episode with Trisha Reo.
Hey, everybody.
So happy to have you all here again. We happen to be in sunny Florida during one of our MSK ultrasound class weeks, and we are so fortunate to have with us today Dr. Jon Jacobson and Dr. Jeff Strakowski.
Woo!
They, of course, are leading ultrasound, MSK ultrasound experts, and we are going to have a wonderful time today, but we'll just give you a brief introduction, and then we will get started and take off with that.
All right, so we are here with Jeff Strakowski, who is currently the clinical professor at the Ohio State University School of Medicine, Department of PM&R, the associate director of medical education at Riverside Methodist Hospital, Department of PM&R, and the director of musculoskeletal research at the McConnell Spine, Sport, and Joint Center. He's also the author of Ultrasound Evaluation of Peripheral Nerves and Focal Neuropathies. Welcome, Jeff. We're glad to have you.
Thanks. I really wanted to point out that we start after hours kind of early here, as you know, the sun's still up, but that's Gulf Coast Ultrasound.
Well, that's the way. It's 5 o'clock somewhere, right?
That's true.
And it's 5 o'clock here.
And it's 5 o'clock here. It's
All right.
Absolutely right. And Dr. Jacobson is the professor of radiology and section chief of musculoskeletal imaging at the University of Cincinnati.
Go Bearcats.
He also is the author of Fundamentals of Musculoskeletal Ultrasound. Yay!
Yay,
So
welcome.
Thanks.
How
Thanks,
are
Lori.
you guys?
We are awesome.
Great.
As always.
Another day in paradise looking out the window here.
Yeah, absolutely. Yep. So we're going to be talking about a lot of things, MSK and peripheral nerve ultrasound. And so why don't you guys get us started here?
All right.
So, Jeff, how you doing?
I'm doing well, John.
You're looking good.
You as well.
Well, thanks.
So we're going to talk a little bit about some of your interests, I guess, and most especially, I'm curious of what you think about some of the biggest problems we have facing individuals doing ultrasound-guided procedures, and the most common error you might be encounter.
That's a very good question, Jeff. Before I give my answer,
Yes, sir.
I wanted to present you with a gift. I haven't seen you in about 3 months. So,
That's
Jeff,
touching.
here you go.
Excellent. What is this called?
MTD Do.
We'll try it. Let's see.
I didn't shake it, by the way.
He's the Mountain Dew King.
Yes. thank you.
Okay, so back to the question. So a large part of musculoskeletal ultrasound is indeed guiding procedures. We can improve accuracy, decrease any complications, and increase the efficacy of all the procedures. So there's definitely a great reason to do it. So you probably thought I was going to say the number one error is not seeing your needle, but I have a different answer. Are you ready?
I am. You
So
caught me off guard, though.
So as a radiologist, I'm asked to inject things all over the body from a whole host of referring physicians. And it's amazing, the indications for the procedures aren't always clear. And the histories aren't always clear. And the background imaging isn't always clear. So before I go into any procedure, the first question I ask myself, I say, what am I treating? If I don't know what the pathology is, how can I direct an effective treatment? So what I'll do is, of course, look for the MRI, look for the X-ray, perform a diagnostic ultrasound. Because if you don't know what you're treating, it doesn't matter where the needle's going. So you have to understand the pathology. So my answer is, we shouldn't walk into this thinking, I'm going to guide my needle to X. The question should be, what is wrong with X? What an anatomic structure? Then I will guide my needle with the appropriate treatment. What do you think about that, Jeff?
I think that's great. Do you find yourself in a position sometimes you have to contact the referring physician and say maybe we need to do things a little differently?
Yes.
You run into that scenario?
Yeah, sometimes it's a struggle as a radiologist because, well, of course, if you're in one institution for a number of years, you develop a relationship with certain people, and then you come together with the thoughts of how can we move forward for the best care of their patients. Sometimes there are outside referring physicians who don't know me from anyone, and they may not even return my call. Then I'm like, well, what do? I want to help the patient, but I'm not going to do something that's not indicated. So I would say it's a struggle, and it just takes time. And then when I do contact the referring physician, I have to be very, very careful because some people get very defensive because I'm not questioning their intelligence. I'm saying, how can I help you take care of your patient best? So it's a discussion, and it goes differently with different people.
Yeah, sure, that's true. I run into the same thing when I get referred sometimes I want to do things differently and end up having to discuss it with a patient. And
so what do you do in that scenario when there's a difference of opinion?
That's more of an art form, I guess, and some of the same things that you described. You have to know the referring person. You have to really kind of feel out what the patient themselves wants. They're ultimately should be part of that decision, I think.
That's a great point. There are some situations where I'll say to the patient, your doctor ordered this, and I'll say, as a radiologist, I'm responsible for your care while you're in my clinic. I'm not comfortable doing this. I tried to contact your physician. We're working through it, but I don't feel comfortable moving forward. I will bring you into my clinic another time and do this at any time, but I'm looking out for you. And the patient understands, so that is a key point. Now, the one area where I'm most critical about this discussion are steroid injections, because steroids are thrown around. Steroids are used for a lot of reasons, and there's a lot of good for use of steroids, but there are a lot of dangers with steroids. Steroids can cause cartilage damage, joint deterioration, and many times it's only temporary pain relief. So especially steroids in the joint in younger people, is it really indicated? So that's where I really take it quite seriously.
I've had the same issue, and I'll have common tendinopathies referred for steroid injections. They may have had 2, 3, 4 injections in the past, sometimes without any benefit, and they think, well, we'll do ultrasound guidance, and that's going to be the magic. And we call that sometimes a get out of my office treatment, where they feel good for a couple of months, but a lot of our literature is showing it's probably detrimental ultimately to be doing steroids for lateral epicondylitis, sometimes Achilles problems, patellar tendon problems, and then you run into the issue of some of the referring doctors haven't caught up to that, so that gets to be a problem.
Yeah.
How about for the just lay person, the patient who might be listening to this? At what kind of questions do they need to be asking to make sure that they're getting the most appropriate treatment, and at what point do they decide, okay, steroids aren't helping?
I think it's challenging because you have, there's some indications for steroids if they're inflammatory, but most of the things we see in musculoskeletal medicine aren't inflammatory, and we're getting away from that. And John, you've, as much as anybody I know, have talked about trochanteric bursitis and how that gets completely overcalled, for example. You talk to anybody that has lateral hip pain, and their doctor or 3 or 4 doctors have told them for years they have trochanteric bursitis, and we know that's almost certainly not the case. If it is the case, it's probably not even the problem. And John, more than anybody, has pointed that out to people. And so we run into having to change the mindset of patient and referring doctors, and it gets challenging.
For sure.
And I agree with Jeff, of course. And it's educating the patient. Like, I'll tell the patient about the expectations. I'm injecting steroids over this tendon. And the risk of tendon rupture is low because I'm using ultrasound guidance and not injecting it into the tendon. But I'll tell them that this is masking the pain. It'll likely come back in 6 weeks. And just be aware that we're not treating the tendon problem. We're masking the pain, that you need physiotherapy. You may need some other type of tendon treatment down the road. So it's education and also expectations, setting realistic expectations with these frank discussions with the patient.
Yeah. Maybe a little transparency, right?
I think so. And I think you can simplify those comments in just the way Jon mentioned. Explain, people understand. I don't want to just mask the pain. I want this to get better, and the word's starting to get out on some of these regenerative techniques and some of the things you guys have been teaching all week here. So,
Absolutely.
And you actually covered this very topic in lecture.
Yeah, and if you notice, my answer was very basic, meaning we could go on to talk about regenerative medicine, all these experimental treatments. It all comes down to knowing the anatomy and knowing the pathology at a fundamental basis to determine the correct treatment. So even without going that far into regenerative, even just simple steroid injection, we need to know what we're treating.
And the value, would you say the value of using ultrasound guidance when performing procedures? Because I know a lot of patients don't realize, the difference between doing a procedure with a landmark technique versus having an ultrasound, and depending upon what physician that they happen to go to for their treatment, they may not have ultrasound and therefore not be, a proponent of that and give reasons why not to do that. And do you have any comments on that in terms of using ultrasound guidance versus not?
I think once the patients, to answer that question, once they've seen it done with ultrasound guidance, it generally takes longer, but they get the idea that, boy, they put some effort into this, and they can see, they know it's in the right place and it's understood, and they have an idea, and I think they really like it. Most of them don't want to go back after they experience that.
I've had many patients say, wow, that didn't hurt this time, or this did not feel like the last time. And we explain, well, we used ultrasound. I saw the needle go right where it's supposed to be. So I think eventually patients are going to request it, maybe not demand it, but say, how come I can't have ultrasound guidance? So I think that will be eventually the trend.
Mm-hmm. Absolutely.
Awesome.
All right. So thank you for that intriguing question, Jeff. And I think we all contributed to some thoughtful answers, and hopefully those who are listening benefited from that discussion. So, Jeff, I was thinking, could I ask you a question?
Certainly. Just one, though.
One question. I just asked you a question.
That's true. So that was it.
Can I ask you another question?
All right, you can ask me two.
That was the second one. Sorry.
We're out of options here.
Okay. So we're here in sunny Florida teaching this course on musculoskeletal ultrasound. Now, there's this concept of neuromuscular ultrasound, and that might be a term that many people may not be familiar with. Yeah. So I was wondering if you could compare and contrast and talk about these different terms and how you approach that.
Sure. And we'll start with the basis of that area of medicine. So musculoskeletal medicine, we're generally talking about joints, tendons, muscles, bones, but also nerves. And there's crossover. Neuromuscular diseases tend to be things that cause weakness. It can be everything from a focal neuropathy, ALS, systemic diseases, things like that. And musculoskeletal medicine has made or musculoskeletal ultrasound has made a lot of leaps and bounds over the years. I'd say it's been really in most of our curriculums now for 15 years, would you say? Somewhere in that length of time?
Yeah, maybe a little more, but yeah.
Maybe more than that, especially from where you came from. So you came from the hotbed of ultrasound. So neuromuscular medicine's a lot more new, but it has to do with neuromuscular type diseases. There's a lot of overlap. I'm primarily musculoskeletal trained initially, but there's a large group of people, particularly those that do electrodiagnosis and have traditionally done nerve and peripheral nerve assessments with EMG and nerve conductions. And if you're not familiar with that, that's where you do most of your testing by shocking the nerve, if you can use that term, and also doing needle EMG. So not as much fun as ultrasound. And
for the patient.
Yeah, and for years and years, people have said to me, you need to come up with a better way to do this. One doesn't hurt so much, and and I think that's happening with neuromuscular ultrasound. So it's really progressed in a way that I think you find where musculoskeletal medicine was maybe 15 years ago, 20 years ago. That's kind of where neuromuscular ultrasound is, where a lot of people that do that are realizing they have to be part of that to stay current. So instead of we've recommended, instead of just saying EMG nerve conductions now, we say EMG nerve conductions and ultrasound really ought to be all part of that assessment, because you get the anatomic and physiologic assessment.
Yeah, so you bring up a couple of great points. One thing is looking at the evolution of the equipment of ultrasound. And I remember starting out barely seeing peripheral nerves, and of course the more you look for things, the more you see them, but the equipment has really helped with that. I know that you have been using some extremely high frequency machines that may not be universally everywhere, but it really can show the details, and that's really the sky's the limit of eventually where we're going to go.
I think so too, and just like you mentioned, that level of resolution is changing what we even know about some of these conditions. Even simple entrapments like carpal tunnel syndrome, you're realizing they're not all idiopathic. There's things that we can see that cause them, and we can define them in greater detail, especially traumatized nerves and other kinds of nerve diseases. So when we can actually see down to the level of fascicles and components of the nerve, it really helps us. Same thing with muscle architecture and muscle diseases, but that also helps even with, fatty infiltration and musculoskeletal conditions. And I think there's a pretty good overlap of these two types of disciplines, and it's regardless of the type of ultrasound you do, if you know significant components of both, you're going to be much more effective. So.
And you mentioned another important point about the ultrasound complementing EMG nerve conduction because they work together, the physiologic and anatomic. The question, is there one indication in the extremity where you feel that adding ultrasound to the physiologic studying has made the biggest difference in the care of your patients?
That's a really good question. I think, a couple things. One thing is, I've always had a problem when we do electrophysiology for an unusual entrapment, something that's not in a conventional entrapment. You always think, boy, it would be nice to image that and see what it really looks like, and just make sure that, just for ruling out a problem that you think's probably got a low yield, but you don't want to spend a lot of expense on assessing that either. Okay, that's one thing. The other, probably more importantly, is when there's anatomic change, like a post-surgical change. So post-surgical carpal tunnel, post-surgical ulnar neuropathy, a radial fracture from a bone fracture, some other issue where you don't have a good history, developed a Saturday night palsy without a really good history of that having developed, and knowing you're not dealing with a mass or some other source of it. It's just a great way to do that and see the anatomic change, know what's been done. We can see that the problem's there, but ultrasound gives you the basis or why it's there.
Very good. So the term musculoskeletal implies muscle and bone, and of course we can see the surface of bone. Now neuromuscular is now bringing peripheral nerve in with muscle. Do you think we should combine the three and call it neuromusculoskeletal or NMS?
I'm okay with that.
Well, how about skeletal neuromuscular SNM?
That's not bad either.
No?
That might catch on even better.
We're going to that one.
And we can put you as the godfather of S&M. Yeah,
kiss my ring.
I'll throw you a fist, but it's COVID right now. We're staying away from the kissing. So,
but I agree with your comments that peripheral nerve ultrasound, we're just coming to form of understanding what we can see and how that complements the physiologic studying.
And there's
great points.
Yeah, and there's even some of these instruments and some of what was primarily EMG or electrophysiology vendors are now creating things that will quantify muscle architecture and things like myopathies, muscle diseases, things that we really didn't have a great way to standardize that. Now that's their interest, and we're getting great instrumentation for that. So that's a really neat thing in the horizon, I think.
All right. So could I go off script for a few more questions?
Sure, absolutely.
I just had a couple questions. It just lets the audience get to know a person better. And I have 4 questions for you, Jeff.
My gosh, okay.
Are you ready? So they're short questions. You just have to pick one of the 2 choices. The first question.
These are all A and B questions? Like
maybe.
Or is it A, B, or D, C, both? Or
Or is it true or false?
I want to
Truth
give
or
you a
dare?
choice, and you pick one of each. I got
Okay.
it for it. So here's the first
Here we go.
question: PC or Mac?
A Mac, by far. That's not even a...
Next question: Nike or Adidas? Now
You know, Nike's been kind of struggling lately, but I've been a Nike person for years, so
because I know that you've been running your whole life.
I have.
And I know you probably were in the era where Adidas, the triple stripe versus the swoosh, was back there maybe when you're in high school.
Yeah.
So I wondered if you historically had picked one of those two.
I actually, so when I was about 12 years old, I won an age group road race, and they gave me, my award was a Nike t-shirt, and no one had even heard of Nike. Okay. Now, I grew up in an Amish town, so that's, we were a little behind.
Explains the hat that you wore on the way in today, too.
Correct. And the
It was
haircut.
nice. It was nice.
So, but it was cursive Nike, and everybody thought it said Mike, and I constantly had people like, your name's not Mike, and
Wow.
so I've been kind of, I use that, it was, to me, that was a nice image thing. I wanted nobody to really know what my shirt said or what it meant, and that felt good. So I've latched on to Nike kind of my whole career. When I started, I ran in Indiana, and our first year we were sponsored by Adidas, and we didn't have the best spikes, we'll put it that way. And then the next year we got some nicer ones with Nike. We switched. So
I could see being at the really cutting edge, front edge of the Nike explosion. You might
He was a
trend toward
trendsetter.
that.
yeah. So it's lately Nike's been taking a beating in the press. So
Yeah, just do it, right?
yeah,
Okay, third of 4 questions: DC versus Marvel.
Marvel. That's not even close. I mean, do you want entertainment, or do you want to be depressed and bored?
How much?
Wait a minute, this
time
could
do
get me
we
in big
have?
trouble.
Oh,
I'm just wondering.
Although the Batman series is pretty good, the Christian Bale Batman.
Okay.
But I'm pretty much a Marvel person.
Okay. Last question: original or extra crispy?
That depends on the day.
You gotta pick
I
one.
usually, honestly, I usually get a mixture.
Both
I'm
answers.
kind of wishy-washy.
how do you do that?
So that ends the segment of
I didn't know
Get
you
to Know Jeff Strakowski. We now know more about him than
You ever wanted to,
know.
or still want to?
Thank you, Jeff, for letting me drill into your personal life.
You're going to do the same, right?
I'm sorry, that's all the time we have today.
So, John, what's your favorite color?
Red.
Red? Oh, wow.
And that's all the time we
And
have.
that's a guy. Yeah, I don't think I'll delve into that.
my watch died, so I don't know where we are in time. So I'll leave that one up to you. No.
So
All
I
right.
think we've covered our topics. Anything
Yeah.
else that we would like to discuss before
Yeah.
we sign off?
Anything you want to talk about? You got anything else you want to talk about?
It's
It's been very
I got one.
enlightening, and
Have you discovered a favorite place to eat in Cincinnati since you just relocated there?
Well, there's a restaurant a block from my apartment called Crown Republic, but there are many great restaurants. There's Taste of Belgium, has great waffles and chicken. There's the Eagle that has these great hot dogs. There's one called the Lindsay Lohan because it's a mess. I've only been in Cincinnati for 9 days, so I've only been to 9 restaurants.
There you
There
go.
you go.
You got to check out Montgomery Inn.
I gave Nathan a choice of any place he wanted to go for lunch, and we ended up at Subway. So
They might have one of those in Cincinnati, I
Yeah.
think.
Yeah.
Let's clarify, Nathan is his college-age
Age
son.
son, right.
So
Who is
we'll
just
take that with a grain of salt.
going back to school after COVID.
But I've heard about Montgomery Inn and their barbecue sauce.
Oh, my.
So I've heard about that from many people already.
oh, it's quite good. It's in Columbus too.
But I have to admit, my favorite restaurant is Grader's Ice Cream.
Yes, so there's 3 things in Cincinnati. Graders, Skyline, Montgomery Inn.
Ah, okay.
there you go.
Which are all also in Columbus, by the way, and BW3s.
All right.
Well,
I
it's
don't
an
think we
Ohio
have them
thing.
here in St.
Jeff, you're
Pete,
only an
but-
hour and a half from me, so
Yeah.
maybe I'll come by and visit, have a Subway there or something.
We have a BW3s.
We can meet
have a
at the
Skyline.
outlet malls. They're like 45 minutes each.
Well, you both have been coming to St. Petersburg for many years and working with us here at Gulf Coast, and so you've had an opportunity to check out a lot of restaurants
Yeah.
and so forth here. So what's your favorite restaurants here?
Where did we go last night?
We went to Doc Ford's, right?
that was pretty
on
good.
The waterfront, and you can see it right from here.
Yeah, that was It was pretty killer.
My favorite is the one that I can see out the window here, where the sign has part fish, part cow on it. What is that? Still water. Yeah, they have great craft cocktails if you're into that. And their food I thought was excellent. So there are many great restaurants, but that's been my favorite one lately.
Yeah. And then, of course, we have the Ale and the Witch.
So I want to give a thanks out
COVID,
to...
would we get nachos and cheese
Right.
put on their menu?
Exactly.
Yes, so the Ale and the Witch, which is downstairs, has great craft beer, and they donated this because they felt sorry for us, so they brought it.
You know how hard we're working.
So thank you, Ale and the Witch.
Absolutely. Well, thank you guys so much. I think we're coming to a close on our time allocated, so we really appreciate you all joining us today for our open mic after hours session here.
Yes, thank you guys so much.
Also for all of your help and your wonderful teaching at our MSK courses and peripheral nerve programs that we have here. So
Well, we appreciate the invitation. So
Yeah, love coming here. Thanks.
Yep,
Both
it's
of
a
you.
pleasure.
well-run
We've got
program.
2 more days, so
Yep.
we're looking
John and I
forward.
both said we do a lot of courses all around the country and beyond, and this is the one place I go, and I think John feels the same way, where we don't have to worry about anything. It's all set for us. We just show up and
Yeah, look at
teach,
this.
and we don't have to.
Yeah.
Yeah.
Yeah, but we do appreciate that. A well-run course makes the biggest difference in the world.
Awesome. Thank you
does.
so much. We appreciate that.
Yes, we do.
Yep.
Okay, thanks everyone.
All right. Thanks,
Bye everyone.
everybody.
Thanks
All
for
right.
tuning
Thanks
in.
for
joining us.
See you next time.
Yep.
Thanks for listening to the Sonography Lounge. Don't forget, if you like this episode, please subscribe and leave us a review on iTunes, Spotify, or wherever you get your podcasts. You can also find us on Instagram at Sonography Lounge and Twitter at SonographyLNG. If you have any questions, comments, or topic suggestions, feel free to send an email to us at sonographylounge@gmail.com. Have a great week and scan, scan, scan.